Question 80. Which of the following best explains the pathophysiology of this patient's condition? Defective integrin-mediated adhesion, impaired T cell, cytoskeletal remodeling. Okay, so we know this is probably one of those biochem immunodeficiency questions. A 10-month-old boy, so he's 10 months, is evaluated for recurrent ear infections, rash, and easy bruising. Born at term, met early developmental milestones. He has had multiple episodes of otitis media and now presents with petechiae and bleeding from his gums while teething. He is anemic, thrombocytopenic, and MPV is decreased. That's one you don't see too often, as well as normal white blood cell count. So probably one of the most commonly tested immunodeficiencies would be your IgA deficiency. IgA is absolutely critical for protecting mucosal surfaces. So think GI infections and upper and lower respiratory tract infections. We've got our ear infections and otitis media, so maybe, but just IgA deficiency is not going to explain why he's bleeding. It's not going to explain the low platelet count either. And I don't even think it's an option. Just keep IgA deficiency in mind when you're going through these. It's one of the easier ones to recognize and very frequently tested. So if we were to go through these from top to bottom, let's start with A. We've got defective integrin-mediated adhesion. So this is probably referring to your leukocyte adhesion deficiency. LAD is usually pretty easy to recognize as well because it results in a strong immune response. However, the cells cannot get to the problem. They can't extravasate out of the blood. So if this is your capillary, and then you've got your neutrophil here, it will try to come down here and then it rolls along the surface of the capillary until eventually it comes to a firm stop once it's held on to some integrins and whatever other biochem junk I forgot. After that point, it'll extravasate into the extracellular space. But with LAD, we might not have these integrins, so it really can't roll and stop to begin with. So you'll get leukocytosis, specifically tons of neutrophils, but if you have an abscess, for example, you won't be able to get any of those white cells to the abscess. So this is commonly referred to as a cold abscess. You can have these infections, but no neutrophils going to them, therefore no inflammation. Inflammation is not due to the bacteria, the viruses, etc. It's due to the white cell response. So look for cold abscesses. They didn't mention anything like that here, so A is out. It also wouldn't explain his low platelets or his anemia. Impaired T cell receptor signaling is referring to the George syndrome, the 22q11.2 deletion. This presents with a myriad of other symptoms. It's multi-system. You get thymic hypoplasia. Thymus is important for T cell education. Everybody remembers that. Hypocalcemia, congenital heart defects. We don't have any signs of that. It's really just the bleeding, rash, and recurrent infections. Defective platelet cytoskeletal remodeling classically refers to Wiskott-Aldrich. That one's associated with the WASP gene. There's a great mnemonic to help you remember Wiskott-Aldrich. It's pretty easy. It's just water. The W and the A stand for Wiskott-Aldrich. The T is microthrombocytopenia. The E is for eczema, and the R is for recurrent infections. So it's a pretty solid mnemonic. The big key with Wiskott-Aldrich is microthrombocytopenia, not just thrombocytopenia, it's micro. So it's small and decreased number of platelets. So if they gave you a smear and showed you really small platelets, or they told you they were really small platelets, or if they told you the mean corpuscular volume for red blood cells, that would be the mean platelet volume for platelets. So MPV refers to the volume inside the platelets, and that is decreased. So you have small platelets. And because you have small deformed platelets, they tend to be destroyed quicker, which is why you have thrombocytopenia. And all of this is due to cytoskeletal remodeling. Actin not able to do what it's supposed to do, so you get defective white blood cells that can't respond to infections as well, hence the recurrent infections. And you get inappropriate inflammation all over the place, hence the eczema. And again, with actin not working, you get these small, ineffective platelets. So Wiskott-Aldrich looking really good right now. Let's just go through, make sure there's nothing better. Failure of phagolysosome fusion is referring to Chidayak-Higashi syndrome. I always remember Chidayak-Higashi because the really weird thing with that is partial albinism. They might also tell you about giant granules and neutrophils, but pretty much all of these have recurrent infections, so that doesn't help. It's really the partial albinism and giant granules if they were to tell you that in a smear. We don't have albinism, so I'm going to cross that one off. They usually do tell you about that. Deletion of RAG1-2 gene complex is referring to SCID. And SCID, the problem there is with VDJ recombination. SCID usually presents very early on. Because of this, they get recurrent infections, and they're pretty bad infections. If you don't have VDJ recombination, you don't have functioning B cells, you don't have functional T cell receptors either. So if we don't have VDJ recombination, T cells and B cells will be non-functional, and T cells might even be completely absent. We have a normal white count. Not going to explain the thrombocytopenia here, or the microthrombocytopenia specifically, so that one's out. Correct answer is C. That is our Wiskott-Aldrich syndrome. Please remember water, put this in Anki. This comes up all the time. It'll get you free points.